Ocular and central nervous system involvement are the basic prognostic factors in Behcet disease. Cardiovascular, pulmonary, and gastrointestinal system involvements are the major causes of mortality. We already observed oral genital aft and erythema nodosum were more frequent in females. However, papulopustular eruptions, thrombophlebitis, ocular, neurologic, pulmonary, and vascular involvement were more frequent in males. The etiology is still unknown, but various genes, especially HLA-B51, various microorganisms such as Streptococcus, herpes simplex virus infections, and the elevation Th1 and Th17 cytokines and lymphocytes have been suspected. We already observed that HLA-B51 and positivity and absence of HLA-B35 can be regarded as laboratory risk factors for vascular involvement. We already observed some genetic mutations such as factor V Leiden, prothrombin gene, platelet glycoprotein 1A polymorphism in vascular Behcet patients. Also, as oxidative stress genes, we already observed glutathione S transferase and acetyltransferase 2 and cytochrome P450 polymorphism in Behcet disease. Also, we already reported a patient, Behcet patients, triggering by imiquimod cream treatment, and we could decide that imiquimod cream could induce the genital and oral lesions via the induction of several cytokines. What about the clinical features? We can see oral ulcer, genital ulcers, erythema nodosum-like lesions, papulopustular lesions, superficial thrombophlebitis, pathogen positivity, and also we can see some other vasculitic skin lesions. As systemic manifestations, we can see uveitis, retinal vasculitis, arthritis, venous thrombosis, central nervous system involvement, gastrointestinal ulcers, pulmonary arterial aneurysm, also myocarditis, endomyocardial fibrosis, we can see as systemic manifestations. We already observed that male patients had vascular involvement about 5 times, neurologic and ocular involvement about 2 times more frequently than female patients. And also, we detected some bone mineral density abnormalities and cardiac complications in Behcet patients due to systemic treatment. The diagnosis of Behcet disease remains purely clinical. In 1990, the International Study Group for Behcet disease proposed diagnostic criteria: recurrent oral ulcers plus at least 2 of the other criteria, including ocular involvement, genital ulcers, erythema nodosum-like lesions, papulopustular eruptions, and pathogen test positivity in the absence of an alternative clinical diagnosis. In differential diagnosis, the cause of oculomucocutaneous syndromes, including autoimmune Belo's disease, erythema multiforme, Reiter syndrome, seronegative arthropathies, sarcoidosis, Swiss syndrome, also herpes simplex infection, lichen planus, syphilis, systemic lupus erythematosus, ulcerative colitis, and mixed connective tissue disease should be excluded. Treatment of various symptoms of Behcet disease remains controversial because of heterogeneity of the condition, lack of reliable laboratory markers of the disease activity, and paucity of controlled clinical trials and unstandardized outcome measures for Behcet disease. In my speech, clinical studies were selected if they were randomized controlled trials, single or double-blind, or interventions with pharmacological therapy compared to placebo or some other pharmacological agents. Colchicine has been used for the treatment of Behcet disease since 1975. The first double-blind study of colchicine was published in 1980. At 6 months, only patients with erythema nodosum-like lesions and arthralgias benefited from colchicine. Another randomized double-mask trial showed that colchicine was less effective than cyclosporin. In a recent trial, the effect of colchicine on the extraocular manifestations was investigated in a 2-year double-blind study. It was superior to placebo among women only. Each sex colchicine 1 to 2 mg per day was effective only for genital ulcers, erythema nodosum, and arthritis among women, but only for arthritis among men. We start colchicine therapy in every Behcet patients, and we believe that the low frequency of ocular and neurologic involvement in our patients may be a result of beneficial effective colchicine therapy. Azathioprine 2.5 mg/kg day decrease weight attacks and preserve visual acuity in a 2-year. Orogenital ulcers and arthritis also improved with azathioprine. Additionally, there was a tendency for preventing deep vein thrombosis. Azathioprine alone or in a combination with other immunosuppressive drugs provides substantial symptomatic relief and may prevent some major complications. The researchers suggested that azathioprine could be useful as a steroid-sparing drug. Early treatment with azathioprine also improves long-term prognosis of Behcet disease. Cyclosporin is usually the first-line agent in severe eye involvement like retinal vasculitis. Cyclosporin A, 10 mg/kg, reduced the ocular attacks and decreased mucocutaneous lesions. Cyclosporin was compared with conventional therapy in 4 studies. Improvement in the cyclosporin A treated group, particularly in uveitis, was shown in 4 studies. In 1 study, orogenital ulcers and arthritis improved more with conventional therapy than with cyclosporin A. In current clinical practice, the dose used is 3 to 5 mg/kg due to side effects. A blinded trial of cyclosporin A versus monthly bolus cyclophosphamide showed that visual acuity improved significantly in cyclosporin A group. In a randomized trial with topical cyclosporin and placebo, there were no difference in oral ulcer outcome. In a recent trial, the combination of cyclosporin A with colchicine was effective in reducing the number of uveitis attacks. As a result, cyclosporin A is the most rapidly acting drug for acute uveitis. The combination of cyclosporin A and with azathioprine gives a significantly better outcome in ocular disease. However, most patients develop a disease flare after drug discontinuation. Thalidomide, 100 mg daily, was effective for reducing the number of oral ulcer and orogenital ulcers and papulopustular eruption in a 24-week study. Recurrence is usual when the drug is withdrawn. Low dosage of thalidomide has been found to be effective papulopustular eruption and orogenital ulcers. It's found to be useful also in neurobehcet disease, pyoderma gangrenosum, uveitis, and gastrointestinal ulcers. The usual oral dosage of the drug is between 100 to 300 mg day for 1 to 6 months. However, it's not recommended as a first-line therapy for mucocutaneous Behcet disease, especially in females. Among non-steroid anti-inflammatory drugs, the efficacy of the azopropazone 300 milligram thrice in a day was no different for acute arthritis than for placebo in a control study. It provides only analgesia during the first week. Interferon alpha 2A subcutaneously 6 million international unit 3 times a week significantly decreased orogenital ulcers and papulopustular eruptions. In a randomized double-blind trial, topical interferon alpha 2C hydrogel was no beneficial for the oral ulcers. In open studies, interferon alpha achieved a partial or complete response in most patients with severe posterior uveitis. In uncontrolled studies, interferon is effective for both ocular and extraocular symptoms of Behcet disease, and long-lasting remissions have been reported after stopping the drug. Its high cost and frequent side effects limit its widespread use. Among anti-TNF agents, etanercept has been found to be effective on mucocutaneous Behcet disease in a randomized control trial. However, another study has indicated that no response is observed on mucocutaneous Behcet disease, which responded to infliximab afterward. High cost and side effects are still concerns with anti-TNF agents. There is also accumulating evidence with TNF-alpha blockers for other manifestations of Behcet disease, such as ocular, gastrointestinal, neurologic, and vascular Behcet disease that are resistant to conventional therapies. Infliximab 5 mg/kg was recommended as an add-on immunosuppressive therapy for patients who are intolerant or refractory to traditional immunosuppressive. In a control study, corticosteroid was tested the efficacy of as the depot corticosteroid in mucocutaneous Behcet disease. It was useful for controlling erythematosus in females. Euler recommends early initiation of corticosteroid for the management of severe systemic manifestations. A 12-month randomized control trial has demonstrated that dapsone is associated with a significant improvement in mucocutaneous Behcet disease. What about the other drugs? Chlorambucil could be useful for ocular and neurological involvement. Cyclophosphamide could be useful for vascular and neurologic involvement. Methotrexate treatment could treat ocular and neurologic manifestation. Antibiotics such as benzathine penicillin, minocycline, azithromycin, and erythromycin could treat mucocutaneous lesions. Pentoxifylline could treat ocular and ischemic leg ulcers. Levomizole could treat orogenital ulcers, arthritis, and uveitis. Tacrolimus treatment could help ocular involvement. Mycophenolate mofetil could treat mucocutaneous and neurological involvement. We can select also granulocyte monocyte colony-stimulating factor for the treatment refractive genital ulcers as intralesional. Granulocyte and monocyte adsorption apheresis could help painful orogenital ulcers and ocular Behcet disease. Intravenous immunoglobulin could treat ocular involvement. Also, oral lactobacillus-containing and low-dose natural human interferon lozenges could help oral ulcers. Pimecrolimus cream also could help mucocutaneous lesions, especially genital ulcers. Sometimes anticoagulation treatment will be necessary for venous thrombosis. Ripamycin can treat oral ulcers. We can use topical corticosteroid anesthetics, antimicrobial mouthwash, and sucralfate for mucocutaneous Behcet patients. Sometimes surgical intervention will be necessary for gastrointestinal ulcer perforation, also vascular aneurysm. We already reported a severe erythema nodosum due to Behcet disease responsive to erythromycin treatment. Recently, apremilast for Behcet syndrome was done, and apremilast was effective in treating oral ulcers in Behcet disease. What about the other biologics? Rituximab, gevokizumab, and canakinumab can treat ocular Behcet disease. There is one case report about anakinra. It will help orogenital ulcers, gastrointestinal involvement, and arthritis. Euler concludes uveitis, orogenital ulcers, and arthritis are mainly evidence-based in Behcet disease. The other organ involvements are based largely on expert opinions and uncontrolled evidence for open trials and observational studies. In our clinic, we selected as a first-line therapy for oral of topical steroids, sometimes systemic steroids, anti-inflammatory instance, also topical anesthetics. In genital ulcers, we use as a first-line therapy topical steroid, sucralfate, oral colchicine, azathioprine, dapsone, and systemic steroids. For popular eruptions, we use as a first-line therapy topical steroids, oral colchicine, azathioprine, dapsone, and prednisolone. For erythema nodosum, we selected oral colchicine, dapsone, and systemic steroids for first-line therapy. And we decide for systemic involvement, we decide with the other department. As never, therapeutic options, alemtuzumab and hematopoietic stem cell transplantation are currently being investigated for Behcet disease. Thank you for your kind attention. I would like to invite our Congress next year, 16 and 20 March, in Istanbul. That's it.